Greetings. This is Mirrakhimov. I work as a cardiac anesthesiologist at the University of Kentucky, where I also serve as a director of point-of-care ultrasound within the Department of Anesthesiology. Today we continue with our Advanced Cardiac POCUS series lectures with part 2. This is for our cardiac anesthesia fellows, our critical care anesthesia fellows, and for residents who are interested in learning new techniques. Let's get started. I have no conflict of interest to report for this presentation. Our agenda for today's presentation is to learn echocardiographic techniques for stroke volume and cardiac output estimation, to review the basic assessment tools for significant valvular heart disease. We'll specifically discuss aortic stenosis, aortic regurgitation, mitral stenosis, and mitral regurgitation. We will cover tricuspid regurgitation in the next lecture. However, the same principles which are discussed here will still be applicable. And finally, we'll review and understand the echocardiographic features and findings in patients who present with pericardial tamponade. So let's start talking about the echocardiographic stroke volume and cardiac output estimation. So first, you need to obtain the diameter of the left ventricular outflow tract, which is typically done in the parasternal long axis view during mid-systole within 1 centimeter of aortic valve opening, as shown here on the top right part of the screen. This is followed by either apical 5-chamber view or apical 3-chamber view, and utilization of pulse wave Doppler, again within 1 centimeter of aortic valve, where you want to measure the left ventricular outflow tract velocity time interval. Here on the bottom right, you see a spectral Doppler profile of a pulse wave Doppler through the LVOT. By tracing this spectral Doppler profile, you'll obtain velocity time interval, which is basically the distance the blood travels with each heartbeat. Please pause the video if you need more time to review this important concept. Let's keep talking about the echocardiographic assessment and estimation of stroke volume and cardiac output. There are several sources of potential error which we need to remember. First is our Doppler angle of incidence for the LVOT velocities via pulse wave Doppler. Again, we don't want to underestimate velocities, we want to optimize the angle as much as we can. The second source of potential error is in LVOT measurement. It is very important for us to accurately measure the LVOT diameter. How do we derive the LVOT area from the diameter? The formula for that is PR squared, where R stands for radius, which is half of the diameter, and P stands for 3.14 number. Again, our stroke volume based on echocardiography will be our LVOT area times LVOT VTI. Our cardiac output will be stroke volume times heart rate, and the cardiac index will be cardiac output divided by body surface area. On the right part of the screen, you see a table with normal values. SVI stands for body surface area adjusted stroke volume. Please pause the video if you need more time to review the slide. Let's dive in deeper into the limitations of this technique. Again, we discussed there's a possibility of LVOT measurement errors, which are then squared. We also assume that the shape of the LVOT is a circular one. However, in many patients, it is a form of ellipse. Again, we mentioned Doppler limitations and angle issues. Again, patients who have beat-to-beat variability and patients with arrhythmias, for example, atrial fibrillation, can have different values each time for the stroke volume. Again, you have dynamic changes in LVOT, especially in patients with hypertrophic obstructive cardiomyopathy, and obviously coexisting valvulopathy can affect the measurements, such as, for example, aortic regurgitation, aortic stenosis, and mitral regurgitation. Please pause the video if you need more time to review this important slide. So let's compare the performance of echocardiography to a pulmonary arterial catheter. Most of these techniques and modalities provide very important information and should be viewed as complementary to each other. Things which are in favor for echo include volumetric measurements, such as, for example, diastolic and systolic area of the ventricles, biventricular systolic function, detection of ischemia and wall motion abnormalities, and assessment of a cardiac structural pathology, such as, for example, aortic stenosis and constrictive pericarditis. Pulmonary arterial catheter is superior for direct measurements of right-sided pressures because this is what it does, such as stroke volume, cardiac output, and cardiac index. It is also superior for right-sided pressure measurements because it's a direct measurement again, such as central venous pressure, right ventricular and pulmonary arterial pressures. Mixed venous saturation. Again, pulmonary arterial catheter is considered to be more accessible in certain patient populations, such as intensive care unit in patients who have limited echo windows or where TE availability is unfortunately limited. And it also provides a continuous information. Please pause this video if you need more time to review this important concept. Next, let's talk about the basics of valvular assessment. It starts with 2D, color flow Doppler, continuous wave Doppler, and supported by ancillary methods, such as pulmonary venous blood flow, hepatic venous blood flow, and flow reversal in the abdominal aorta. Let's continue with 2D valvular assessment. We want to examine the valve opening and leaflet motion, whether it has normal, excessive, or restricted leaflet mobility. Study the valve thickening and calcification, presence of valvular masses, vegetation, and chamber clots and thrombi. Assess the chamber size, such as, for example, left atrium and mitral valve disease, and left ventricular hypertrophy, for example, in patients with aortic stenosis. Here, on the top right image of the screen, you see a clip of a peripheral long axis view. You see two valves in this view. You see aortic valve, which appears to be opening pretty well, and you have a mitral valve, which appears to be very restricted in its mobility. You see the left atrium appears to be enlarged, and the anterior mitral leaflet has this so-called hockey stick deformity. This is suggestive of mitral stenosis in the setting of rheumatic heart disease. Compare this to this image from the bottom right. Again, you have a peripheral long axis view. You have aortic and mitral valves. Aortic valve seems to be opening pretty good again, but the mitral valve, especially the posterior leaflet, appears to be prolapsing back into the left atrial cavity. This suggests that the patient has mitral regurgitation, and left atrium appears to be somewhat enlarged as well. Please pause this video if you need more time. So after we finish the 2D assessment, it is time to follow this up with a color flow Doppler. You want to visualize the whole jet in order for you to be able to assess its severity. You want to assess the direction of the jet, whether this is a central jet or comes from the center of the valve or eccentric jet. You also want to assess the vena contracta and look for flow acceleration through the valve. On the bottom left of the screen, you see a frozen image of a jet. This is a full jet because you have a flow convergence or FC. You have vena contracta or VC, which is the narrowest part of the jet. And this is typically reflective of regurgital orifice area. And then you have a jet expansion. On the top left of the screen, you see apical 5-chamber view with some flow acceleration through the aortic valve and then eccentric aortic regurgitation going back towards the LV cavity. And on the bottom right of the screen, you have apical 4-chamber view focused on over the mitral valve, and you see that there is significant eccentric mitral regurgitation there. Please pause the video if you need more time to review this important slide. Next, we discuss color M mode, or combination of color flow Doppler and motion mode. This is quite often used in assessing the aortic regurgitation. In order to utilize this method for aortic regurgitation, you want to obtain peristernal long axis view, focus on aortic valve, Place color flow Doppler box over the aortic valve and LVUT, and apply the M mode through the LVUT with the use of color. And you want to measure the ratio of the aortic regurgitant jet diameter to LVUT diameter, as shown on this image on the top right. You see the walls of the LVUT and the bluish mosaic color of regurgitation jet in between. So in this particular case, it is quite significant aortic regurgitation because the jet diameter is almost the same as the diameter of LVUT. Please pause this video if you need more time to review this concept. We can also utilize the continuous wave Doppler to help us understand the significance of the regurgitation. You can assess the density of the jet and its contour. The density of the jet tells you how many red blood cells are crossing backwards. Again, remember that if you're not catching the jet well with your continuous wave Doppler cursor, you will likely underestimate the jet, which is especially true in eccentric jets. Compare different jet pathologies on the bottom part of the image. You have a trace mild MR. On the left part of the screen, you have a moderate mitral regurgitation in the middle, and you have a severe mitral regurgitation. See that severe MR has significantly higher density than moderate MR, and moderate MR has more density than the trace or mild MR. Also notice that because of significant MR on the right part of the screen, you see a rapid pressure rise and a triangular shape of the MR jet contour. Compare this to more parabolic in the moderate MR. Again, this is an indirect way of assessing the significance of regurgitation with any regurgitation lesion, not only with mitral regurgitation. Please pause the video if you need more time. Next, let's talk about the pressure half-time for aortic regurgitation. It can be used to assess the severity of AR. In order to obtain this measurement, first get either apical 5-chamber or apical 3-chamber view. Place color flow Doppler box over the aortic valve and LVUT, and apply continuous wave Doppler through the center of the regurgitation jet. This technique is based on the pressure gradient between the diastolic aortic pressure and LV diastolic pressure. You want to measure the slope. Most machines will have the capacity to calculate the pressure half-time for you. It is important to remember that it becomes less accurate for chronic aortic regurgitation compared to acute regurgitation because of the pressure equilibration and rise in LVDP. Some of the cases which can lead to acute aortic regurgitation include aortic dissection, infective endocarditis, trauma, among many others. Severe aortic regurgitation is suggested when the pressure half-time is less than 200 milliseconds, which is shown in this table. Please pause the video if you need more time to review this concept. Next, let's talk about abdominal aorta views, especially long axis, because this can be used to help us understand how significant the aortic regurgitation is. Again, you want to use either phase array or curvilinear probe, and you want to image the aorta for this particular reason in the long axis view as shown at the bottom left. So what do we need to obtain in abdominal aorta? We want to study whether the patient has or not whole diastolic flow reversal in the abdominal aorta, which is used in assessing the severity of aortic regurgitation. Again, why do we choose abdominal aorta? Some degree of diastolic flow reversal is normally present in the ascending aorta, aortic arch, and proximal descending aorta. So when present in the abdominal aorta, it is usually clinically relevant. Again, we discussed that you need to obtain long axis view, utilize color flow Doppler, and pulse wave Doppler. Here on the right part of the screen, you see a spectral Doppler profile of an aortic regurgitation assessment. Above the baseline, during systole, you see a positive reflection. And during the diastole, which is marked by yellow arrows, you see whole diastolic flow reversal. Again, when present, this signifies significant, likely severe aortic regurgitation. It is important to note that Some other conditions can sometimes lead to whole diastolic flow reversal in the aorta, such as ruptured sinus of Valsalva, arteriovenous fistula, and sometimes even severely reduced aortic compliance, which is seen in the elderly. But nevertheless, this is a very important supportive feature which you can utilize in assessing how significant is aortic regurgitation in a particular patient. Pulmonary venous flow spectral Doppler can be used to assess the severity of mitral regurgitation and support your findings. Again, like discussed earlier, sometimes it is challenging to obtain pulmonary veins on the transthoracic echo, but usually the right upper pulmonary vein is easiest to obtain. You want to place pulse wave Doppler 1 to 2 centimeters into the right upper pulmonary vein. Normally, you have S-dominant flow. On the left part of the screen, you see a normal pulmonary venous flow. We have negative atrial reverses wave, you have S wave, and you have D wave. Atrial reverses wave is negative because during atrial contraction, there are no valves in the pulmonary veins, and the pressure rises in the left atrium, which causes the blood to go backwards. When you have a D-dominant flow, which is shown in the middle of this figure, it's typically suggestive of a moderate mitral regurgitation. And on the right part of the screen, you see systolic flow reversal of S wave being below the baseline. When you see systolic flow reversal in pulmonary veins, it signifies a significant and severe mitral regurgitation. It is important to remember that in certain cases of mitral regurgitation, you may have a normal pattern of pulmonary venous blood flow. This is typical for eccentric jets, which preferentially go into one pulmonary vein, which you may not be studying with this technique. So again, absence of systolic flow reversal does not necessarily rule out significant and severe mitral regurgitation, especially when used TTE for that matter, because TTE, you don't often have the luxury of visualizing all pulmonary veins. Please pause this video if you need more time to review this concept. Next, we discussed hepatic venous flow spectral Doppler, which is quite similar to pulmonary venous Doppler profile. Sometimes you have a V wave, which is a retrograde flow wave not present in the pulmonary venous Doppler profile. V wave itself doesn't always show on hepatic venous Doppler profile either. So please pause this video to review these waves and their significance. And in order for you to obtain hepatic venous flow, you can get IVC view and see the confluence of hepatic vein and IVC place color flow Doppler and put pulse wave Doppler within 1 to 2 centimeters into the hepatic vein. This concept can be used in assessing the severity of tricuspid regurgitation, which we'll discuss later. So let's keep talking about the hepatic venous flow spectral Doppler. Like I said, you obtain subcostal four-chamber view, then find hepatic vein draining into IVC, place a pulse wave Doppler 1 to 2 centimeters into the hepatic vein. Normally you have S-dominant pattern. Again, if you have D-dominant pattern, this is suggestive of moderate tricuspid regurgitation and elevated right atrial pressures. On the top right of the screen, you see a normal hepatic venous profile, and on the bottom right, you see systolic flow reversal, which is consistent with severe tricuspid regurgitation. Some other conditions can give you A-wave reversal, such as severe right ventricular failure, pulmonary hypertension, restrictive cardiomyopathy, and presence of a pacemaker. Diastolic flow reversal can be seen in constrictive pericarditis and pericardial tamponade. So because we are utilizing TTE, the A reverses wave will be above the baseline, and S and D wave will be below the baseline, which is opposite in TEE. Please pause the video if you need more time to review this important concept. And again, it is important to have EKG tracing so you can better time the significance of events and its timing to different parts of the cardiac cycle. So let's summarize what we've learned about the valvular regurgitation. Again, I refer you to the American Society of Echocardiography guidelines for more in-depth review. Vena contracta, consistent with severe mitral and tricuspid regurgitation, is more than 7 millimeters, whereas when it is less than 3 millimeters, it signifies mild MR or TR. Vena contracta, which is suggestive of severe aortic regurgitation, is typically more than 6 millimeters. When utilizing color mode for assessing the aortic regurgitation, it is considered to be severe when it is more than 65% and mild when it is less than 25%. So next we discuss on some basic tools how to assess for valvular stenosis. Again, we will start with 2D assessment, including the size and function of the preceding chamber, trace the valvular area, and utilization of color flow and continuous wave flow Doppler through the valve. So first, let's discuss mitral stenosis. The etiology of mitral stenosis can be broken down into three main groups, such as supravalvular, including LA mass or myxoma, ring, or membrane, valvular, such as rheumatic, being the most common, moratic endocarditis, which is a non-bacterial thrombotic endocarditis, MAC, which stands here for mitral annular calcification, and radiation valve disease. Some valvular mitral stenosis is usually due to parachute mitral valve. Parachute mitral valve has only one papillary muscle. Let's start with 2D assessment of a mitral stenosis. You want to study and examine the valve opening in peritoneal long axis view, peritoneal short axis view at the mitral valve level. You want to assess the size and function of a left atrium in the peritoneal short axis view of the aortic valve level. You want to study apical views, subcostal four-chamber views. Again, assess the left atrium size, screen for presence of spontaneous echo contrast, also known as smoke, and obvious thrombi. And you want to assess the right-sided function because quite often patients with significant mitral stenosis develop right ventricular dysfunction and pulmonary hypertension. Here on this view, on the top right, you see a patient with restricted mitral valve mobility and enlarged left atrium suggestive of some degree of mitral stenosis. Here in this apical four-chamber view, you see significantly dilated left atrium and minimally opening of a mitral valve, again signifying likely severe mitral stenosis of some sort. And here in this view, peritoneal short axis view at the aortic valve level, you see significantly dilated left atrium, which is very dysfunctional, and you see a lot of spontaneous echo contrast or smoke, which signifies very sluggish flow within the left atrium and high risk for blood clots or thrombi. Please pause this video if you need more time to review this slide. Color flow Doppler can be quite helpful in indirectly assessing the likelihood of stenosis. Here on this particular video clip, you see color flow Doppler box placed over the mitral valve. And you see very mosaic flow acceleration coming from the left atrium into the left ventricle, suggesting that there is likelihood of some stenosis present. Quite often, patients who have mitral stenosis will also have some degree of mitral regurgitation, and you want to assess for that as well. And this is present here, probably some amount of trivial to 1+ mitral regurgitation. Please pause this video if you need more time to review this concept. Let's talk about mitral valve planimetry, which is tracing the orifice of the mitral valve. In order to do that, you need to obtain peritoneal short axis view at the mitral valve level, zoom in, and trace the area in mid-diastole. Mitral valve area less than 1.5 centimeters squared is considered to represent severe mitral stenosis. Take a look at these two frozen images here. One on the left, where the mitral valve seems to be opening pretty good, and one on the right, where you have a very narrow and tight mitral valve area. The image on the right signifies significant mitral stenosis. There are certain limitations which we need to remember. Again, you can be foreshortening the left ventricle at the base, leading to some errors in your measurements. And also, for mitral valve area, you need to obtain this tracing at the level of leaflet tips. But with 2D imaging, you don't always know exactly where you are. So if you're not on the leaflet tip, sometimes you can overestimate the mitral valve area. Nevertheless, this is a very important tool which can be utilized in assessing the likelihood and severity of mitral stenosis. So let's talk about continuous wave Doppler assessment of mitral stenosis. You can obtain either 4-chamber or 3-chamber apical views, place color flow Doppler over the mitral valve, and apply continuous wave Doppler through the center of inflow. You can estimate your valvular gradients and also pressure half time through the mitral valve, which can be used in assessing the mitral valve area indirectly. Let's discuss gradients through the mitral valve. Most machines now will have some software to calculate this for you. However, when not available, you can estimate the peak pressure gradient by utilizing simplified Bernoulli equation, which is 4v squared, where v is your maximal velocity. There are certain limitations which we need to keep in mind. Gradients are flow dependent. For example, patients who have higher heart rate and coexisting mitral regurgitation will have more flow and thus higher gradients. This can potentially overestimate the severity of mitral stenosis. Patients who have reduced LV compliance and diastolic dysfunction will also tend to have higher gradients. And this is because left atrium will now have to eject blood into the stiffer LV cavity. Nevertheless, when everything else fits, such as your 2D and planimetry, gradients through the mitral valve can be important in assessing the severity of mitral stenosis. Mean gradient of more than 10 millimeters of mercury is strongly suggestive of severe mitral stenosis. Please pause this video if you need more time to read this concept. You can also obtain a pressure half time and indirectly assess the mitral valve area via continuous wave Doppler. Pressure half time represents the amount of time which takes for the pressure gradient between the left atrium and left ventricle to decrease by 50%. It is most studied in patients with rheumatic mitral stenosis. In other populations, such as, for example, bioprosthetic mitral valve stenosis, it can sometimes overestimate the mitral valve area and underestimate stenosis. In many cases, the software will calculate the mitral valve area for you. However, when not available, you can use this formula, which is 220 divided by the pressure half time of this particular patient you're studying. On the right part of the screen, you see a frozen image on how to properly measure the slope of pressure half time. And again, they recommend using slope number 2, not slope number 1, as shown on the top right of this the screen. Please pause the video if you need more time to review this important concept. Let's switch gears and talk about aortic stenosis. Again, we can break it down into 3 main groups. Supravalvular, usually due to congenital causes such as Williams syndrome, or related to large vessel vasculitis, such as, for example, Takayasu. Valvular aortic stenosis, which is usually the most common cause, such as degenerative, less commonly congenital aortic valve abnormalities, such as, for example, bicuspid or unicuspid aortic valve, radiation valve disease, and rheumatic aortic stenosis. Again, when rheumatic aortic stenosis is suspected, it is important to remember that mitral valve is almost always involved in these patients. And subvalvular aortic stenosis, such as, for example, subaortic membrane, hypertrophic obstructive cardiomyopathy, congenital narrowing of the left ventricular outflow tract, congenital mitral valve abnormality with redundant tissue obstructing the LVOT, and ejection of the left ventricle. Please pause the video if you need more time to read this important concept. Again, we start with 2D assessment. You want to assess the valve opening and cusp separation in peristernal long axis view, peristernal short axis view at the level of the aortic valve, apical 5-chamber and apical 3-chamber. Cusp separation less than 8 millimeters is associated with severe aortic stenosis. Also, quite often, peristernal short axis view at the level of the aortic valve, you can understand the anatomy of the aortic valve, whether it is normal trileaflet valve or whether this is a bicuspid valve. You want to assess the LV size, function, and hypertrophy. For example, here in the peristernal long axis view, you see that the cusps of the aortic valve are minimally separated during systole, and you see significant left ventricular hypertrophy. Please pause this video if you need more time to review this concept. Color flow Doppler is an important tool in assessing and working up patients with aortic stenosis. You want to look for flow acceleration. You need to know exactly where this flow acceleration starts happening. Is it occurring at the level of the aortic valve itself, or within the subvalvular apparatus, such as, for example, in a patient who has subaortic membrane, or in the supra-aortic or supravalvular area? Similarly to mitral valve area, you can utilize planimetry of the aortic valve. In order to do so, you need to obtain parasternal short axis at the aortic valve level and trace the area of the aortic valve when it is fully open, typically mid-systole. Aortic valve area less than 1 centimeter squared is consistent with severe aortic stenosis. CW Doppler can be useful in assessing the severity of aortic stenosis. You can do that either in apical 5 or apical 3 chamber views. Place the continuous wave Doppler through the center of aortic valve inflow. Severe aortic stenosis is consistent when the peak velocity is at least 4 meters per second and mean gradient is at least 40 millimeters of mercury. Again, most machines will be able to auto-calculate these values for you, but when not available, you can use simplified Bernoulli equation to obtain peak gradients to the aortic valve. Please pause this video if you need more time to review this concept. All right, let's talk about the basics of pericardium. Normally, it has multiple functions, such as it prevents cardiac dilation, controls the coronary vascular tone, aids in venous preload and right ventricular filling. Normally, it contains approximately 5 to 30 cc's of fluid. It has two layers, visceral and parietal layers, so the pericardium. Though it is an important structure, its absence is not required for survival, and many patients with congenital absence of pericardium do just fine. Let's discuss the role of pericardium for venous return and right ventricular filling. Pericardial pressure under normal circumstances mimic pleural pressures. They become negative with inspiration and go back to baseline during exhalation. Normal pericardium aids right ventricular filling. Let's understand how. Let's take an example. For example, our CVP is 10 and inspiratory pericardial pressure is -5. So 10 minus -5 equals 15 millimeters of mercury, which is the gradient for right ventricular filling. Please take more time if you need to understand this concept, and I'll also refer you to this link for more in-depth review and analysis. So let's discuss the flow patterns through the tricuspid and mitral valves, both during negative pressure ventilation and positive pressure ventilation. Under normal physiological conditions in healthy patients, tricuspid valve inflow change approximately 20% during spontaneous ventilation, and for mitral valve change approximately 10%. Let's first start with figure 2A and figure 2B. Figure 2A is negative pressure ventilation for tricuspid valve, and figure 2B is negative pressure ventilation for the mitral valve. You see that in figure 2A, during inspiration, the EV velocity is increased, and this is because the filling of the right ventricle and the right heart is augmented. And again, the EV velocity during expiration goes down compared to the inspiration. And this happens because the RV filling is decreased during expiration. And look at the mitral valve next. You see that during inspiration compared to expiration, in mitral valve you see higher EV velocity during expiration. And this happens because under normal negative pressure ventilation, the filling of the left ventricle is higher during the expiratory phase. Next, we talk about figure 2C and figure 2D, which represent positive pressure ventilation for tricuspid and mitral valve, respectively. You see that the changes here are reversed for the most part. For example, during positive pressure ventilation, the tricuspid E velocities are much lower than E velocities of tricuspid valve during mechanical expiration. Also, you can see that inspiration or mechanical inspiration for mitral valve, you have a higher E velocity compared to E velocity during expiration. Please pause this video if you need more time to review this important concept. As discussed, the etiology of pericardial effusion can be due to infectious causes such as viruses, bacteria, autoimmune such as systemic lupus erythematosus or SLE, malignancy, metabolic such as hypothyroidism, end-stage renal disease, and trauma, which could be blunt or penetrating injury. So let's talk about the volume versus rate of accumulation and risk of pericardial tamponade. It's all about the timing. If you have a rapid rise in the pericardial fluid and pressure without the time needed for the pericardium to adjust, your patient will likely develop tamponade even with 50 or 100 cc's of fluid. Compare this to more gradual and chronic accumulation of pericardial fluid, where the pericardium has all the time it needs to adjust and stretch. Such patients may have large volumes such as 500-600 or even more, and no evidence of pericardial tamponade because the pericardium had enough time to adjust. These patients can still develop tamponade at a later point if the volume continues to accumulate and the limit of pericardial stretch is reached, and then the pericardial pressure will start rising very rapidly. Please take a look at this graph, which shows you the relationship between cardiac output, feeling pressures of the LV, RV, and interpericardial pressures as well. And on the bottom part of the screen, you see two concepts which we discussed, such as rapid accumulation and gradual accumulation and the risk of pericardial tamponade. So how can ultrasound assist us in understanding whether the patient has tamponade or not? We can do this with study assessment by studying the size of the effusion, whether the effusion is free flowing or loculated, and whether a chamber collapse is present or not. You can also assess the transmitral and transtricuspid inflow velocities and profile, and utilize some ancillary methods such as IVC size and collapsibility and hepatic venous flow profile. Now let's review the 2D assessment in more detail. Again, we need to know the size and diameter of the pericardial effusion, which should be measured in the diastole. We need to study whether the effusion is free-flowing or loculated, which can help us understand the next best step towards its drainage. Presence of septal bounce, swinging heart, and chamber collapse, such as right atrial systolic collapse and right ventricular diastolic collapse. Here you have a table with different sizes of effusion and approximate volume. Here on this bottom left of the screen, you see a subcostal view with significant pericardial effusion and compromised filling of the right ventricle. You see also likely blood clot in the pericardial fluid space comprised of the right ventricle. And on this image on the right part of the screen, you see what is called a swinging heart, which is present when the heart is swinging within a large pericardial fluid sac. On EKG, this is often seen as electrical alternates. The septal bounce occurs because of the pericardial constraint due to the amount of fluid the patient has. So during aspiration, right ventricle fills, and because of this constraint, the only way the heart can move is by shifting the septum towards the left because of high right ventricular pressures. Please pause this video if you need more time to review this important concept. We can use the flow pattern through the tricuspid and mitral valves in assessing the likelihood and significance of pericardial tamponade. Remember that with negative pressure ventilation, tricuspid valve has approximately 20% variability and mitral valve has approximately 10% variability, which is exaggerated in patients who have pericardial tamponade and spontaneously breathing. Tricuspid valve variability becomes approximately 40%, and mitral valve inflow variability becomes approximately 25%, which is due to pulsus paradoxus. With positive pressure ventilation, you have reduced preload to both right ventricle and left ventricle. You also have decreased variation through the transventricular valves, which signifies reduced preload. That is why mechanical ventilation and intubation can be a very dangerous thing for a patient who has pericardial tamponade. So let's talk more about the POCUS paradoxes, which is shown on the right part of the screen. Again, you have the pericardial constraint, so the heart doesn't have enough space to accommodate the filling. So with inspiration, you have the filling of the right ventricle, and because of that, you develop the septal bonds, which we discussed before, which further limits the LV filling, LV ejection. That's why during inspiration, you'll have a decrease in arterial pressure, which is typically reversed during expiration when the LV filling goes up and LV ejection goes up again. So POCUS paradoxes is a very important concept to remember. Here in this presentation, we mentioned that IVC can be used in estimating the chances of your patient having pericardial tamponade. Plethoric IVC, which is defined as less than 50% collapsibility, has a 97% sensitivity for pericardial tamponade. But because there are so many different things which can give you dilated IVC, the specificity by itself is quite low. So if your patient doesn't have plethoric IVC, he or she is unlikely to have pericardial tamponade. But if your patient has plethoric IVC by itself, it doesn't mean that the patient has pericardial tamponade. Please pause the video if you need more time to review the slide. Let's discuss the hepatic venous flow profile in patients with pericardial tamponade. Quite often, these patients will have decrease in S and D wave amplitudes. Reversal of flow during spontaneous or negative pressure expiration is quite worrisome, and it potentially suggests PDRS situation. Let's discuss the pleural effusion, specifically left-sided pleural effusion and pericardial effusion, and how to distinguish between the two on the cardiac point-of-care ultrasound. This can be an area of confusion sometimes. So pericardial fluid is anterior to the descending aorta, and pleural fluid is posterior to the descending aorta. So let's take a look at these two peristral long axis views. Let's start with the left-sided video clip first. This patient has pericardial fluid because it is anterior to the descending aorta. Contrast this image to the right one, where you have a pleural effusion and atelectatic lung with this left-sided pleural effusion, because this is posterior to the descending aorta. Descending aorta is a circular structure just beneath the left atrium and posterior mitral valve leaflet. So let's summarize. Echocardiographic estimation of cardiac output has reasonable accuracy, but it is important to keep in mind the limitations and potential sources of error. Cardiac ultrasound is essential for distinguishing between severe and non-severe valvulopathy. Size of pericardial effusion doesn't always predict tamponade. Right ventricular diastolic collapse, plethoric IVC, and swinging heart are commonly seen in patients who have pericardial tamponade. Finally, I want to thank you for your attention. If you have any questions, please do not hesitate to contact me on this email address provided on the slide. I wish you all the best and good luck.